Good afternoon. Thanks, Mon, for letting me present first. I'm going to talk about LV function assessment, mainly ejection fraction, okay, using nuclear and cardiac CT technique. Historical perspective. The first attempt to non-invasively measure LV ejection fraction was done with nuclear technique. As you can see, this paper publication by Dr. Brownwell over 50 years ago. Look at the title. I think back then the ejection fraction as a term wasn't even invented. So it was called fraction of LV volume ejected per beat. A ventricular end-diastolic and residual volume. Obviously right now we call it LVEF, LVEDP, and LV and systolic volume. But this is probably more accurate because residual volume, we don't always get the end systolic. So anyway, so just a historic. And obviously, first attempt to link LV function with the prognosis, a lot of, and especially valvular heart disease, was done with nuclear technique. The seminal paper with AI, MR, was all done with nuclear technique. So what nuclear technique we use? There's two ways. Just, this is a growth scale. So the two way of measuring EF here. You can do it like the LV angiogram, okay? Imagine instead of injecting contrast into LV cavity, we inject radioisotope into the LV cavity. So you're imaging the blood pool, okay? That second approach, which we use it more commonly, is we look at the volume by measuring the wall, by imaging the wall, just like echo, CT, or nuclear, and MRI. Okay, you trace the wall and you get the volume of the cavity. Okay, so for blood pool imaging, this was done earlier. We don't do this anymore. This is mostly for historical perspective. It's called first pass radionuclear angiography. So it's similar to LV angiogram, but you're imaging the radioisotope as it transits through the human circulation. You're going to see showing up the IVC, right side of the heart, pulmonary arteries, and then LV, and then, in a delayed phase. So it's a primary imaging. This could be done associated with exercise. And as a matter of fact, the first attempt to do exercise stress test was using RNA rather than echo, okay? So this is, MAGA is something that we still do occasionally. I believe we did about 6 cases last year. So instead of imaging the first pass, we let the red cells labeled with radioisotope establish equilibrium inside the circulation. And you are not measuring any volume here. You're measuring the count, okay? So you have pre-specified projection, the LAO and AP, try to separate RV from the LV. So you establish where the ventricle is. You count how many, basically you measure the counts emitted from that area, and you subtract the background, okay? And you look at end systole and diastole, so the difference of count in percentage give you the LV ejection fraction. So no geometric assumption at all, okay? If it's done well, good technique, this is one of the most reproducible and EF assessment. As you can imagine, it could be done in there's essentially no contraindication. You could have renal insufficiency, you could have liver failure, whatever. This could be done. So this could be useful in some LVAD patient that you want to measure the LVEF, for instance. In some old school oncology still use this, okay? All right, so I'm not gonna go through it because we very rarely use it. I think every time you do one, you should celebrate that pretty soon we won't be doing any of the MAGA. Anyway, so second part. So this is the part that we measure the LV volume, not by blood pool imaging, but rather establish the contour of the cavity using a three-dimensional algorithm, and that has automatic myocardial age detection algorithm with some threshold put in and some presumption of where the anatomy and LV cavity will be, okay? So this is almost entirely automated, meaning you have very little human interaction, again, making it rather reproducible, which doesn't mean accurate, but it's very reproducible, okay? I'm sorry, let me see. Okay, I guess the video is not playing. All right. So like all the gated technique, which except for echo, MRI, CT, and nuclear, this is a gated technique. Essentially, image the cardiac cycle multiple times, and then you divide it, each cardiac cycle in different percentage, and then you establish the volume in different part of the cardiac cycle, you come out with ejection fraction. Remember, with the current SPEC technique, with the technetium agent, when we give low dose, I mean, the EF, the signal is not as good, so the EF is not as accurate. But with the high dose technetium, the EF is is pretty good. But ideally, you want to do 16 frames. If you do 8 frames, you can imagine you might not get the true end-systolic and diastolic volume, and the result will be an underestimation of the ejection fraction. And this has been validated, again, a bunch of different techniques. Overall, it's clinically useful, right? So what are the caveats? Obviously, you need to have a good algorithm that can establish the contour of the cavity. If you cannot see the contour of cavity, or you have a hot spot like gallbladder, and mistaken that the algorithm mistaken that as part of the heart, you're going to have very bad EF, right? And the Achilles tendon is a special resolution is really bad. We're talking about 1 to 1.5 centimeter, okay, compared to CT with 0.5 millimeter. So, and the partial volume effect, especially in patients with small heart, arrhythmia, like all the gated technique arrhythmia, again, the result is not reliable. RV, because it's very low signal, you cannot look at RV-EF, okay? So this is the most important thing. You get an EF, but you need to do the quality check, and you need to look at the sinogram or the count histogram throughout the cardiac cycle. If you have those spikes right there, that usually is a bad sign, okay? The algorithm essentially established that only take counts that are within 20% of the average heart rate, okay? Basically, which counts that, the R interval is too short or too long, because in that case, you're not gonna have accurate end-systolic and diastolic volume. And if you reject more than 20%, the gated result is not reliable. If you have PVC more than 1 to 5, 1 to 6, also not reliable. So this is probably the most important size, okay? And you need to look at this QA check. In the sinogram, if you see the horizontal striping, okay, in the sinogram in the middle, and you see the growth spiking in the count histogram, usually you probably don't want to report that as EF, okay? And this is just an example of a patient with very large anterior MI, and the algorithm has a hard time tracking. I mean, although I have to confess, oftentimes it surprises you how well it tracks the edge, even if your eyes cannot see it, and they really do a pretty good job. In small heart, again, you see that all the time, EF like 90%, right? This is because end-systolic volume, partial volume effect. Okay, the reference value, EF with nuclear special SPEC imaging is lower than we usually see. 50% for male is probably a normal EF. What are the clinical utility? Well, it helps us improve the diagnostic accuracy. As you can see here, the gating, if you have perfusion imaging plus gated imaging, function imaging, it makes you more confident in calling it normal or abnormal rather than intermediate. So makes you more confident in calling, and we do this all the time. If you have fixed defect and normal wall motion is, by definition, most likely an artifact. And there's been shown to improve the specificity, okay? So you don't end up calling a lot of false positive. And obviously, PET with better image quality, you can get EF very accurate at rest or stress, okay? And especially with rubidium, short life, you can get actually post-stress EF, which also a predictor of outcome. Like this paper published Dr. Malahfji when he was like you guys, a fellow, and in Boston, and he showed that EF, not only EF, resting EF is important. You know, if your post-stress EF increase less or does not increase more than 5% or actually drop, is a bad sign. Similar to, you know, same thing you can see that with SPEC. But SPEC, usually with exercise, and if it's a mild drop, you don't see it, but if you see a drop in EF, exercise, and SPEC, usually that's even worse because you're imaging later. If you're imaging 15, 20 minutes later, you still have drop in the EF, that means that the lesion usually is severe or extensive. Severe, right? Usually the left main disease, proximal LAD. Okay, so this is important. Okay, I know when you guys do PET, this is routinely reported. All right, so that's with nuclear. Any question? Okay, moving on to CT. Okay, why even bother with CT? Okay, so this is just an example of patient for TAVR, and you know, echo, EF is called 45, 49%, but you know, the confidence is probably, you got a lot of guessing. And one motion, forget about it, right? You can do MRI, obviously, but since patient, you know, definitely has a severe AS. Okay, and this is a CT, as you can see, you know, not a perfect study because the contrast is not to the degree we like, but this EF is very reliable. You can get RV, LV, EF. So this CT is useful in this situation, all right? When echo kind of give you equivocal result, you just kind of confirm that. You can always get MRI, but if you need to go to the CT already, this information is important, okay? All right, why is CT attractive? I mean, you all know, I mean, it takes less than less than 30 seconds to get a study done, right? Single breast hold is very easy on the patient. If you want, because of radiation and contrast, we'll probably be doing this in every single patient because it's so easy, right? And the resolution, spatial resolution is the best. And reasonable temporal resolution, you know, heart rate more than 670 or 80, I'm not so sure we get, you know, but it'll tell you if it's normal or normal. Won't be as accurate as MRI. And the important thing is the very good contrast between ventricular lumen and myocardium most of the time, not as good as MRI, but better than other technique. And you can do it with patient with device. And we talk about this during CT talk already, and all this is due to what we call isotropic resolution, okay? Because all the three axes, the resolution is the same. You can manipulate this, you know, the data in different axes that you want. You're gonna get always a perfect volume. And traditionally, there are two ways of measuring it, okay? The hard way, like what they do in MRI, manually tracing, or fellow's hands, although you guys have better automatic segmentation algorithm right now. So it used to be quite painful for the fellow. Spend your MRI rotation tracing it. Or 3D, okay? This is complete threshold, basically track the difference of Huntsville unit between what they think the edge between the myocardium and blood cavity. And this is, again, completely automated. You can, you know, with a little bit of AI help, determine where is the mitral plane and where is the apex. You can get any cavity you want in any part of the cardiac cycle. And obviously, most of the stuff, software we use now has AI component to it, okay? So there's some chamber and myocardial edge by you know, really complicated mathematical formula, which I obviously don't understand, come up with the output is a segmentation, and it takes into account mostly 3D methods with some AI help. You can see that people, you know, you guys rotate through the CT lab, you can adjust the threshold, you know, you can pick up if you want to include the popular muscle, you increase your sensitivity. If you want to exclude the pop muscle, you decrease the sensitivity. And RV most of the time is still done with 2D methods. So 3D and 2D methods, okay, you can see, usually our software includes trabeculation and pop muscle most of the time, okay? Different from MRI. MRI, usually you guys try to exclude it. But either 3D or 2D, I mean, obviously the volume is not the same, but for practical purposes, this is for research purposes, there's difference, but for clinical application, essentially, there's no big difference, okay? And I will talk about this, you know, obviously you cannot have arrhythmia like all the gated method. And MRI versus CT, as you can see, the correlation is if not perfect, almost perfect. And the caveat is similar to what we talk about, right? Underestimated EF because our temporal resolution is not as good. We almost never catch the real end systolic and diastolic volume, all right? And especially if you only divide into 10 phases rather than 20 phases. What do I mean by that? If you gauge the images every 5% of the cycle, you're probably gonna get a little bit more accurate, okay? So, so overall, compared to CMR, echo overestimate EF, CT underestimate EF. Okay, we talk about, unfortunately, I cannot play the videos, but 20 phases give you a little bit more accurate EF, and then pop muscle excluded and included. Again, this is mostly for research purposes. Clinically, it doesn't make a whole lot of difference if you include or exclude the pop muscle. Or other caveats, you know, sometimes we always, or most of the time, we use beta blocker, maybe not for valve cases, right? So if you really want to look at the coronary and EF, if you give beta blocker, it might depress the EF a little bit. Obviously, radiation and contrast is the main issue. And this is the normal volume. So, Man, let me know, does it differ too much from CMR, or is it essentially?
It looks very similar.
Yeah, I mean, you know, it's the same, similar technique. So, yeah. so obviously there's not as much data in terms of normal value for CT yet, because, but you know, we usually when we do study, we report the MR value. Okay, and like any other technique, when you have EF, you add prognostic information, regardless if it's ischemia, or regardless if it's coronary disease, severity. You get EF, you get better. Okay, so how do we get when you want an EF and CT? Traditionally, we do retrospective gating. We have the detector turned on and the X-ray source on throughout the cardiac cycle. All right, so you get beautiful wall motion, you get perfect curve, but at cost of radiation, right? We can do dose modulation. You could drop the radiation maybe from 20 millisievert to maybe 10 or less than 10 millisievert, but still, you know, doesn't justify doing this just for the EF, right, the radiation. But there's some twist to it. With the new technology, you can technically get EF by getting imaging the heart in end systole and end diastole. Either use step and shoot, okay? You can open the window from 30 to, let's say 90%, that give you a relatively decent EF, or the GE scanner allows you to image only around 30% and 90% if that's what you want. The problem is, you know, end systole, end diastole, we almost never use for coronary assessment. Okay, so but if EF is normal, you know, if you have ejection fraction calculated by end systole, they say 30% of cardiac cycle and 80%. It's normal already, you know, EF is gonna be even, the real EF is actually higher, right? Because you're not imaging the end diastole, right? You're imaging late diastole. If anything, you need to add a little bit more to the volume. But if you look at this heart, I mean, you know the heart, EF is gonna be normal. May not be accurate, may not be exactly, but you can technically, if you want to, you don't want to give too much radiation, you can image the heart in 30% and let's say 95% and get an EF. Okay, same thing with the high pitch mode. And you know, I do a lot of double flash. For instance, this case was done in 30% and then maybe 75 or 80%. If EF look like this already, and the true EF probably even higher. So this patient had normal EF. Okay, so if you see this, you can report EF is normal. I wouldn't put a number. Okay, if the EF is in borderline, I wouldn't say anything because you're not getting the true end-diastole. Does that make sense? Okay, and the most important thing that you can also see the wall motion. Okay, this is a lady coming with a lesion in LAD. You can see even with two phase, right? You can see the wall motion in the LAD territory. And if you look at the parametric imaging, in the middle is a thickness, and the right-hand side is a perfusion. This is a perfect case, obviously. And this, not many people talk about this from RomiCat, right? The wall motion detected by CT. This study was done mostly with the retrospective. It's a lot more, maybe even more predictive than the coronary disease. Kind of makes sense. If you have wall motion caused by coronary disease, that's very, very, very specific. And that's why I emphasize every time you read with me that besides looking at the coronary, also look at the myocardium, right? All right, what's anything interesting? How about non-contrast CT, right? We published this paper last year. The volume using AI algorithm, you can measure quite accurately the LV volume. So someone could be thinking, okay, if I have non-contrast CT in end-systolic end-diastole, I could potentially get an ejection fraction. We need to prove that, but actually we have data. We're preparing the manuscript. So this could be important because when you do a non-calcium, when you do a calcium score, now you're adding information, the volume and potentially EF. That would be a very important piece of information, and we increase the utility.
Even the RV looks good.
RV actually works better because LV, we cannot see the myocardium. So RV actually works very well, and atrium even better. Okay, so, all right. How about non-EF LV function assessment? You don't know about strain, okay, CT, essentially we can do anything the other technique do, but the problem with the radiation and contrast, you're not gonna get a strain using, okay? But there's something, also strain, you require dedicated software, it's hard to do. But one thing CT I think could potentially be useful in patients who undergo multi-phase CT due to valvular disease. Like this paper shown that this is kind of like a much easier way to look at long axis shortening. How's that different from, let's say, TAPSE or mitral annular systolic shortening, right? This takes into account the length of the LV, whether mitral annular systolic only is an absolute value. Okay, this is relative, right? So this is kind of poor man longitudinal strain, but really easy to do. And the important thing is CT is the only technique that allows you to do it because it's a 3D acquisition. You can always find the mitral plane perfectly. You can always find the true apex, which you don't necessarily be able to do with echo or even CMR if you don't prescribe the plane perfectly. So MRI can do it, obviously, but this could be done almost. The reproducibility was very good at inter-observer. So this could be something interesting for, and this paper actually showed that this parameter was predicted mortality in patients who were supposed to undergo TAVR or severe AS and having medical therapy only, was a predictive outcome even independent of LVEF. Something of interest for research. Okay, in conclusion, volume and EF assessment by nuclear and cardiac technique, cardiac CT, are feasible and very accurate, provide additional prognostic information. I think it's essential for patients who are difficult imaged by echo, unable to go do MRI, like patients with LVAD, or undergoing imaging for coronary disease assessment, for ischemia, CAD assessment, and you have the opportunity, and patient has known prior ventricular assessment, especially patients who show up with acute coronary syndrome. I think getting some type of wall motion in EF is very important. That's all. Question? Okay, Mon.
Thank you, Dr. Chang. All right, everyone. I'm Malahfji. I think there's a few of the first-year fellows that I haven't met yet. And I'm going to talk about the CMR aspect of LV function, hemodynamics, and how we assess all these parameters. So I'll show you some caveats, and as you guys have experienced already, EF is one of those critical parameters that everyone wants to know. Are there any of the first-year fellows here, by the way? Let's see. No? Nice. Okay. So some are here. All right. Welcome. All right. So here's a person. This is actually not a patient. It's yours truly. And here's another one. We get an EF of 65% in both of them. Do you notice any differences between the two cases for the first-year fellows in particular? And thick myocardium? This is measured within normal, actually. This is actually my own heart, so I hope it's normal. This was a scan I had 5 years ago now, probably. It may appear because you're looking at it primarily as systolic, but if you pause it during diastole and you measure it, it's still within normal. I'm going to recheck after you told me this. What about the person on the right? So you're correct that this heart looks significantly larger than this. And then what else do you see?
I mean, there is something in the mitral valve on the right side.
So there's a posterior leaflet flail of the mitral valve with severe MR. You see the jet of mitral regurgitation kind of directed anteriorly. And then you see the posterior leaflet. Here's the posterior leaflet. Here's the anterior leaflet. And you see how the posterior leaflet goes beyond the valve plane during systole. So although the two individuals have the same EF, their hearts are quite different. Wouldn't you agree? So my EDV is 164. This person is 259. And then systolic volume is calculated at 57 with a stroke volume 107. And then this is 91, 168. But this person is getting all of their LV forward flow going through the aortic valve, whereas this patient has significant MR with a regurgitant volume that's going backwards into the LA of 92 mLs. So they still end up with a pretty sizable stroke volume that's going forward, very similar to this person, despite very dramatic differences between those two hearts. Now take a look at this one. What do you guys think of this heart? What's that?
LV dilation is the contrast.
Yeah, so there's swirling due to kind of slow flow. You see, it's actually a very nice example of how the vortices form within the heart. You see how the inflow through the mitral valve and then kind of rotates, goes towards anteriorly and then comes out of the aorta. And then you said severe LV dilation, right, just visually. Wall motion changes, what do you guys think?
Anterior apical hypokinesis or akinesis.
Yeah, really akinesis in the anteroseptum, the apex. MRI fellows, what do you guys see in addition to this also? Well, we don't see the inferior wall here. So this is inferolateral, but there's hypokinesis also. Yes, it's not as bad as here. There's also probably fatty metaplasia. Wouldn't you agree also? You see that darkness here. But, more on the topic, EF 23%, ventricles huge, 434, insystolic volume. There's very minimal MR. And actually, he still has the same forward stroke volume that's reaching the body as these two guys. So you really have to consider all these aspects. When you have someone with an advanced cardiomyopathy, their EF may be 15. But because the LV is very large, they may still actually generate a decent stroke volume. Now, that doesn't obviously take into account what happened to this patient with exercise, how their PA pressures are, or how their afterload is. So keep in mind all these aspects, but remember that there's a lot more to the heart's performance than EF. That's the message. So cardiac output and EF don't necessarily correspond. The EF doesn't incorporate the LV size. It is load dependent, which we'll discuss also. And then regardless of these caveats, EF has, like Dr. Q says, withstood the test of time. So probably shortly after the Brownwell paper, EF as a term has came around and is still here and we still use it. But to get an ideal index of performance of the LV, particularly in contractility, you need a measure that is sensitive to changes in inotropy, which EF may not necessarily be, independent of preload and afterload, heart size, heart mass, easy and safe, and then proven with prognostic data. So there hasn't really been a parameter that's non-invasive and meets all these criteria very well. But EF is still something that we will stay with and work with, and it's easy to obtain. We can calculate it easily. You can track it. You can visually estimate it with good experience, and there's a lot of prognostic data that supports its use in a variety of cases. So where does MRI fall into all of this? So MRI has high spatial resolution, so you can delineate structures from each other very well. So you can tell where the LV begins, where the cavity begins, and then it has high temporal resolution, so you can delineate the motion of moving structures. For temporal resolution aspects, think of it as the shutter speed of a camera. So if you have something that's moving rapidly, for you to resolve the movement of that object, you need high temporal resolution. Excellent signal to noise means that for any imaging technique, there's noise that's inherent to the image, to kind of think about it simply. But the signal of the true structures as a ratio to the noise is very high. So you can delineate what's not real versus real, essentially. And then you can create all sorts of imaging planes. So remember, with echo, you have to put the probe on the patient, and you have to be able to acquire an imaging plane that shows you the structure that you want. Here, you can have essentially a 3D volume where you can decide where exactly you want to image, and you prescribe that plane, and you take images wherever you want. So this kind of image that shows the RV inflow with the RV outflow and gives you the tricuspid valve and the pulmonic valve and the PA, this is really hard to achieve with echo, as an example. There's no need for geometric assumptions, which is going to be very critical for the volumes and the EF assessment. So how we do this is a little bit different than CT. For CT, think about it, you're kind of acquiring sections of the body, right, from top to bottom. Here, it's essentially an acquisition through those planes that we alluded to. So you get a plane that kind of covers an axial slice of the body. You draw another plane that kind of creates what we call a pseudo two-chamber view. So you have LV and LA, and then you create a third plane that has the four-chamber view. And then out of these, you prescribe what we sort of delineate as short-axis slices of the LV that are perpendicular to each other through the four-chamber and the two-chamber. And then you know what the distance between them is. You know what the positioning of them in that kind of the 3D space of the magnet. And then you end up with these slices. So if you trace each of these as end-diastole and end-systole, and you know what the distance between them, you can still apply the Simpson's method, similar to how we do on echo, except here that you can actually get the true contour of the heart as opposed to any geometric assumption. So you have those, let's say, 7 or 8 slices. This one, if you trace it, you get 41. You add these up to get to the 206. And then you decide where your end-systolic volume is, and you do the same. And now you have your EDV, your ESV, and EF. Like Dr. Chang was discussing, whether you include the papillary muscles within the mass versus the volumes is very important. A key thing to do is to do it persistently. Your mass can be quite different if you include the articulations and the papillary muscles versus not. And then obviously, if you do it on one scan in 2022 one way, and then you decide to do another way, you can create illnesses for the patient that don't exist. So you have to be careful with that. For us, we include the papillary muscles within the mass, and there's a lot of nuanced conditions where that's important. So including the papillary muscles within the mass now is considered standard, essentially. One thing to keep in mind when you trace these is your heart is moving up and down by about usually 10 millimeters. So when you trace end-diastole, that same plane that you created at the end of systole will be higher up within the LV relative to this. So here, there's going to be spots that show up as the LV, but then during end systole, part of it may be all the way. Account for these when you're tracing these, and this is where experience becomes very critical to really achieve that high inter-observer variability with MRI. So you use that long axis to to rely on as a reference to where you trace or where you not trace. That's very important for the right ventricle. So in reality is, anyone can kind of trace a lot of things, but if you don't account for these things, you can end up with errors. And like I said, you can have patients who had 300 mLs on one scan, but then 250 mLs on the other scan, and the heart is still the exact same. So you have to keep these into account. So gadolinium, for all of what I've shown you so far, is not really needed. So this is a non-contrast study that you can do in 10 to 15 minutes, and it doesn't really require any contrast. The reproducibility is very good, like I said. So inter-study is about 5% for volumes and EF by extension. And then intra and inter-observer is also very low. However, this is really for normal size hearts. When you get to those hearts that I showed you earlier with 500 mLs, the reality is the variability can be a little bit higher. This is extremely well validated against animal models, in vivo, ex vivo. This was a study from '85 that actually used excised postmortem left ventricles and actually create sort of a latex model of the left ventricle and compare the volumes on MRI versus the true volume of the LV. And that's very important for trial design and sample size calculations nowadays with, if you have some device that is supposed to improve LV performance and reduce ESV, you may want to do an MRI to use as the gatekeeper to decide on entry into the trial and how you follow patients in the trial. So in terms of how we include this, it's a little bit different than CT, where the actual imaging data is acquired as K-space lines into what's called the K-space. And that's kind of like a canvas of frequency information rather than actual images. So MRI is generally considered a slower technique to acquire than CT, let's put it that way. So you need to get K-space lines through the RR cycle, and then let's say you want to create one image. If you take a few K-space lines from one beat, you get an image like this. So it's not like you're going to get one section and then you're going to get another section and a third, but rather each of the lines contributes something to the information. And as you acquire more beats, in this case, if you do those 3 full beats, you can refine and improve the resolution of your image in terms of contrast information and then edge detection to end up with those very nice pictures that I showed you earlier. Now, what if you want to see a movie like the heartbeat that I showed you earlier? This essentially requires what we call segmentation, where over multiple heartbeats, you acquire the same information and you kind of bend them to the RR cycle, similar to Dr. Chang showing you how we did it for nuclear. And then you put it together, all of this information through those 5 heartbeats to generate a moving image. Generally, we use 25 phases or frames to get you that time resolution of about 45 milliseconds that Dr. Chang was referring to. And that's really where you get very crisp detection of things that we care about, like the LV wall motion. Now, for someone who's not able to hold their breath, and that for that acquisition that I showed you earlier, that takes about 5 seconds. It gets you a resolution of about 1.5 millimeters, which is highly adequate with the frame rate that I mentioned earlier. If you have someone who's not able to do the 5 seconds breath holds, we used to do what's called real-time imaging, where essentially there is no breath hold needed, and you're acquiring images with a high acceleration factor, if you will. And that comes at a sacrifice of both spatial resolution as well as temporal resolution. But notice here the advantage, you can see real-time motion of the heart, just like with echo. So I would argue very often, even this will look much better than many echo images we get, right? So nowadays we do what's shown here on the right, and that's what's called compressed sensing. And it's an algorithmic way of speeding up the acquisition. It gets you a better spatial resolution, a better time resolution as well. It takes longer to process, but nowadays with improvement of all the processing techniques and NVIDIA, like I said earlier, those processing powers have improved dramatically. So nowadays, really all you need for many scenarios is for the patient to be able to lay flat in the scanner and tolerate being in the scanner. And this really can speed up the acquisition, because the acquisition itself is much faster than this. It's just the processing that takes longer. So how do we compare relative to echo measures? We have standardized normal values for men and women, and then by age groups. Generally, there is kind of a separation between older versus younger individuals, but really we have normal data for the spectrum of, teenage age individuals all the way up to the 70, 80 plus year old individuals. The end diastolic volume, for example, for men, notice the range here is 161, but that is dramatically different than what you have on echo for normal data, which is 62 to 150. So the upper limit is 203 here versus 150 for echo. And that's really what we see very often as the inter-study variability between echo and MRI. With 3D echo, there's improvement, so you get larger numbers. Here's the index value. So for men, the upper limit of normal is 86. It's still not the same as you get with MRI, whereas here 100, but still significantly better or closer to MRI numbers than what you get with non-3D echo, essentially. So keep those in mind. Also keep in mind that normal ventricular volumes are usually lower as in older individuals. The threshold for what's considered a normal EF is higher in older individuals. So if you have, a 21-year-old with otherwise, normal exam and no symptoms, an EF of 50, 52, 53 may be really normal compared to someone who's older. And then even with indexing to body surface area, and indexing is a big, complicated topic that we don't want to get into. There's still differences between men and women for normal values, even when you index them. For ejection fraction, it's not as big of a deal. There's high consistency between all methods, really, whether it's MRI, unenhanced echo, contrast echo, and then MUCA as well. And this was a study that really included the spectrum of low EF. This is really a seminal study now from 2008 that compared 3D echo against MRI volumes. And even with 3D echo, as we saw, there is still a negative bias where echo underestimates end diastolic volume by up to 67 mLs against MRI. Same thing for end systolic volume, 41 mLs. EF difference is very minimal. As you get more experience, your variability is lower, and this is what they found in this study. The analysis time back then was much longer, and the acquisition was tough. Nowadays, all of these have improved. The challenge is, so far, you can't really combine contrast echo with 3D echo very easily. So you guys have all probably tried to do 3D measurements off of TE and TTE using commercial software. And the challenge is very often where you detect the true muscle. So in the same study, they had a phantom, and this was a balloon that they know for a fact is 150 mLs. And notice with really just minor changes of where you trace, you can get a dramatically different result. So if you trace on the inner edge, you get 127. In the center, you get very close. Just with minor changes to the outside of the balloon, you get very dramatically different numbers. And this is what they found as one of the key conclusions of this paper, is that essentially echo has a hard time delineating the trabeculations, and this is very pronounced at very large ventricles. If you trace on sort of the inner aspect of the trabeculations, you end up with actually very good agreement with echo, but this is not what we do on MRI. So for you to really get good agreement with MRI and echo, you have to really trace as far as you can. You have to make sure there's no foreshortening. Even with that, you still have to recognize that some variability will be there, particularly in large hearts, so keep those in mind. So cardiac volumes are higher on MRI compared to 2D echo, compared to 3D echo. The variability is improving, but you have to recognize that there's still going to be a difference. LVF can be slightly higher on CMR or slightly lower. It depends really varies from one study to the other, and kind of the technique of tracing, particularly in that basal slice that I mentioned earlier. And then let's talk about function beyond EF. So diastolic function can be assessed. It's still primarily in the research setting. You can actually do what's called a phase velocity map or a phase contrast MRI, and that actually shows you velocities of flow. So in this case, if you do one through the mitral valve, you get an E wave and an A wave. Those low velocities, such as the E and the A waves, tend to be underestimated on MRI compared to echo. But in some studies, it actually showed pretty good accuracy in detecting, E to E prime ratios that are abnormal and normal. And then same thing for TR velocity. Usually it's very low, right? So you can underestimate that on MRI, especially because of the valve moving up and down, and then the temporal resolution limitations. There's aspects to MRI that are not there on echo, so you can get what we call ECV, and that's essentially a measure that infers interstitial expansion and potentially interstitial fibrosis within the myocardium. Obviously, that will be elevated very often in people with diastolic dysfunction. You get accurate left atrial volumes, and then strain measures, and then LA strain measures. So all of these are very helpful in this assessment. In terms of non-EF systolic measures, so there's the MAPC, which is the annular systolic exertion, that descent of the annular plane during systole. And essentially, that's also found to be prognostic on MRI, independent of findings and clinical parameters, as well as in people with normal EF. You can get strain measures, which relies on what we call feature tracking, and then, as you may expect, similar to echo, it's a powerful independent of mortality in those with ischemic cardiomyopathy, non-ischemic cardiomyopathy, incremental to EF and LGE. We don't routinely report it, but I think the more data that comes, and then the more information, particularly about how and whether this is actionable or not, will probably lead to us using it, similar to echo. So, my fourth message is you can assess diastolic function, you can assess LV mechanics. There's many advanced techniques to look at vortices within the LV, like I showed you earlier, and then obviously there's an AI aspect to all of this now. That's a very big deal. But currently, we're not kind of routinely reporting and using all these parameters. So things for you to consider using MRI for. So really, these days, almost anyone with a new diagnosis of heart failure, especially if you're uncertain about the etiology, or that there's no ischemic cardiomyopathy aspect to it, really deserves an MRI, and now there's a lot of data to support that. An inherited or acquired cardiomyopathy that is suspected, such as HCM, dilated cardiomyopathy, and infiltrative disease, and those with cardiotoxic agent exposure, or those who require follow-up, such as those with valve disease, really MRI has become almost standard of care in many institutions to follow these. But you have to keep in mind all those caveats that I mentioned about how you trace it and how you interpret the results. And then revascularization and medical therapy. This one, we may have to rethink, but currently it's kind of considered appropriate use criteria. And then a big source for the MRI businesses, if you will, is also those with arrhythmias. So frequent PVCs, unexplained ventricular tachycardia without a known cause is a very big indication. And I will stop here, I believe. Yeah. Questions? Let's see, what time is it? All right. Thank you all.